Thank you and good afternoon, everybody. First, I would also like to thank the organizers for inviting me to this exciting meeting. When Peter asked me to give a talk about dialysis treatment in patients with extreme electrolyte disturbances, I immediately agreed as a clinical nephrologist, but soon I realized that I might get some problems. Why? Because there are no outcome data for dialysis prescription in patients with extreme electrolyte levels. So we have to keep in mind that the background for this talk is based on pathophysiologic principles, rather limited observational studies that were mainly done in the maintenance hemodialysis population and mostly clinical observations. And the results are heterogeneous recommendations based on an expert opinion level. So in the next 30 minutes, I will focus on hemodialysis as renal replacement modality and 5 clinical scenarios: hyperkalemia, hypo and hypernatremia, hypercalcemic crisis, and severe metabolic acidosis. So, if available, I will present evidence and recommendations and then basically do a case-based discussion for the treatment of extreme electrolyte disturbances. So let's start with potassium management. There seems to be a U-shaped relationship between serum potassium levels and all-cause mortality. But after correction for multiple confounding factors, only hyperkalemia remains significantly associated with mortality. Almost the same is true for cardiovascular mortality in the hemodialysis population. However, a modest significant correlation with cardiovascular mortality also remains after multiple correction for hypokalemia. But in general, if you look at the subgroup analysis, for each of these subgroups, hyperkalemia was found to be bad in terms of mortality and cardiovascular mortality. The causes of hyperkalemia are well known in the end-stage renal disease population. Mainly, it's diet, medication, and the failing kidney function. So how do we define severe hyperkalemia? So it's a potassium above 6 or above 5.5 with warning signs like arrhythmia, hyperkalemic ECG abnormalities, muscle weakness, ascending paralysis. So for the treatment of severe hyperkalemia, let's do a virtual patient case. Emergency room situation, a patient comes with AKID and potassium far above 8. So he presents with ECG abnormalities. So the first thing you do is you apply calcium gluconate 1 gram over 2 minutes. In order to antagonize these ECG changes, and then you will apply insulin plus glucose and sodium bicarbonate if metabolic acidosis is present in order to redistribute potassium into the cells and to gain some time before you can start the dialysis treatment. And you will also start to try to remove potassium from the body by applying potassium binding agents like SPS or newer agents. But usually this conventional therapy will not bring back your potassium to safe levels, so you have to finally start dialysis treatment. And once you start dialysis, you should generally stop the redistributive therapy with the hemodialysis start because you don't want to increase the post-dialytic rebound. And if it's possible for you, you can use glucose-free or glucose-reduced dialysate solutions in order to increase the potassium removal by about 30% due to less redistribution. So when it comes to dialysis, some general considerations first concerning the dialysate potassium prescription. Usually it's based on pre-dialysis serum potassium levels, but there's no general consensus and no randomized control trial evidence. So the risk with low dialysate potassium bath is arrhythmia and sudden cardiac death, and the risk with high dialysate potassium is interdialytic hyperkalemia due to inadequate removal of potassium during the dialysis session. So what guidelines do we have for the choice of dialysate potassium? These are guidelines from an Australian hospital, and I included the up-to-date guidelines in this overview. If your serum potassium is below 4, you can use K4 to avoid hypokalemia, of course. Between 4.1 and 5.5, it's suggested to use K3 or K2, and there's no safety difference between these two potassium concentrations. I will show you the evidence for that later on. But of course, this is based on individual trends in the maintenance hemodialysis population. Above 5.5 up to 6.5 serum potassium concentration, you should start your dialysis with K2 bath and of course do longer hemodialysis hours and do dietitian and medication review. If your potassium is above 6.6, you should start with K1 bath and then increase your dialysate potassium to 2 if your serum potassium comes down to 6 or lower, and of course do long hemodialysis hours. Whenever you use K1, you should do a telemetry monitoring, regular potassium checks, and also a 2-hour post-hemodialysis check of your potassium. But I have to mention that some centers never reduce the potassium bath below 3 in patients with high risk for arrhythmia, like for patients with coronary heart disease or left ventricular hypertrophy. Why? Because there's a large body of evidence that observational evidence that lowering the dialysate potassium below 2 or below 1 comes with an increased risk for arrhythmia and sudden cardiac death. Those studies also found that there's no safety difference between using K2 or K3. And interestingly, one of these studies also found that your dialysate potassium is not associated with your next session serum potassium. So we have a dilemma with the management of severe hyperkalemia. The evidence I showed you is that low dialysate potassium is associated with sudden cardiac death and arrhythmia, and so several groups suggest not to go below 2. And other groups even go further. They recommend to do so-called constant gradient dialysis to avoid rapid potassium decline during dialysis. So you should start with higher dialysate potassium concentrations and then subsequently lower your dialysate potassium bath to keep the potassium gradient constant. But on the other hand, a low dialysate potassium bath is necessary to achieve adequate potassium removal to achieve normal serum potassium levels after the post-hemodialytic rebound. And another problem is that all the observational studies I showed you before were predominantly done in patients that were non-severe hyperkalemic. And if we do a closer look in these studies and into the hyperkalemic subgroup analysis, interestingly, it was found that there's no evidence for any increased risk with low dialysate potassium baths. Also below a potassium bath concentration of 1, there was not an increased risk of all-cause mortality. And that's why there are heterogeneous guidelines. This center in Ireland, if the serum potassium is above 5.5, they use K1, or in some patients, named patients only, 0 dialysate potassium baths. We don't do this, but we regularly do a K1. And a recent review article suggested to generally use low dialysate potassium concentrations whenever severe hyperkalemia is present in order to achieve adequate potassium removal. So the rule of 7 was reintroduced in this article to determine your dialysate potassium bath concentration. You should sum up your serum and dialysate potassium concentration to 7. And meaning, so if your serum potassium is 5, your dialysate potassium bath should be 2. And the rationale behind it is that your post-dialysis serum potassium is usually within 0.5 milliequals of the initial average of your serum and dialysate concentration. And it seems to be safe because it was shown in a study with more than 1,000 hemodialysis patients over 5 years that those dialyzed by the use of the rule of 7 had a similar risk of death compared to the controls. So move on to sodium management. If we use baseline serum sodium, it seems that only hyponatremia is associated with increased risk of mortality. But if we use time-varying serum sodium concentrations, both hypo and hyponatremia are associated with mortality in hemodialysis patients. So there's a large body of evidence that hyponatremia is bad and common. Some general considerations first concerning dialysate sodium prescription based on observational study evidence only, and the world is split. Some centers do fixed and some individualized dialysate sodium prescription. Individualized means that it's based on the pre-dialysis serum sodium concentration. But there's evidence now that the dialysate sodium concentration you prescribe is not even associated with the next session serum sodium level. So this makes it a bit complicated. What happened over the decades was a constant increase in the level of prescribed serum sodium concentrations. And in the last decade, the range of dialysate sodium prescription became even wider. Why? Because of the lack of good data. So from a pathophysiologic point of view, whenever your dialysate sodium concentration is higher than the serum sodium concentration, you will apply sodium during the dialysis, you will increase thirst, the sympathetic zone, you will expand your volume, this will lead to hypertension, left ventricular hypertrophy, and finally, to increased mortality and morbidity. If your dialysate sodium concentration is more than 2 or 3 milliequals below the serum concentration, you will decrease osmolality, reduce ultrafiltration tolerance, and again will develop intradialytic hypotension, myocardial ischemia, and increased morbidity and mortality. So let's do an emergency room case report. A 70-year-old woman, 50 kilograms, presents with emesis lethargy, abdominal pain since 1 week due to urinary tract infection. She has a purely controlled hypertension. Her hemoglobin is very low, creatinine is sky high, her serum sodium is 113. She has elevated neck veins, pulmonary congestion is oligoanuric. Hemodialysis is indicated. But how to deal with a serum sodium of 113 and hemodialysis? So if it's acute, developed within hours, of course you can aggressively correct it, and conventional hemo is fine with standard dialysate sodium concentrations. But if it's chronic, over days or weeks, rapid serum sodium correction, of course, must be avoided due to the risk of osmotic demyelinization. And this ODS is rarely described in hyponatremic hemodialysis patients, only if your delta serum sodium increases more than 20 milliequals per 2 hours. Probably the uremia disequilibriation might be protective, but however, it is recommended to increase your serum sodium concentration not more than 6 to 10 milliequals per 24 hours, as it is recommended for the general population. So, but we have a problem, because how to achieve a slow sodium correction rate during hemodialysis? In severe hyponatremia, when the lowest available dialysate sodium concentration is 130. So one approach is to lower blood flow to slow the sodium transfer to blood. So if we know our delta sodium we would like to achieve and the distribution volume, we can calculate the amount of sodium, the absolute amount, for correction. So if the delta is 6 and the distribution volume 25 liters, it's 150 milliequals of sodium. And if we divide it by the maximum sodium transfer per 1 liter of blood flow, that is defined by the sodium gradient between dialysate and blood, in this case 130 minus 113, it's 17, you get the blood flow that is necessary for sodium transfer. And in this case, it's 9 liters. If you do 3 hours of hemodialysis, it's a blood flow of 50 mLs per minute. If you do 2 hours, you can increase it to 75. It's pediatric mode, but it's possible. For a 100 kilogram person, it is 100 milliliters per minute. And it's possible with conventional hemodialysis with low blood flow and using the lowest available dialysate sodium concentration. It's a simple strategy to control hyponatremia during hemodialysis. But of course, you should do hourly sodium controls and apply 5 dextrose in water if your delta sodium exceeds 6 to 10. But of course, you have to deal with a reduced blood flow and a reduced KT over V. So another elegant way to deal with hyponatremia is to do continuous renal replacement therapy. But of course, like for CVVH, the replacement fluid concentrations that are commercially available usually in these bags is 140. And again, you have to customize the replacement fluid. You have to add or replace water. And to estimate what sodium concentration you need in the replacement fluid bag, you need a kinetic model. But the benefit of this approach would be that you don't necessarily have to reduce blood flow and KT over V. But how to customize the replacement fluid? Again, let's look at the case report. Another young woman, 50 kilograms, now with even severe hyponatremia, 98 milliequals. She has AKID and edema, and 4 liters of ultrafiltration are planned in 24 hours. So there's a formula that was published in 2014 that can help you to estimate the replacement fluid sodium concentration to achieve your desired delta sodium. So we can fill in 98 for the initial serum sodium, a desired delta, for example, of 10. Then we have the distribution volume and the dialysate, which is a function of blood flow, replacement fluid flow, and ultrafiltration, and the sieving coefficient. And this finally leads to a replacement fluid sodium concentration of 112. So there are elegant tables that help you how to add or replace water to achieve 112. You either can add 1.25 liters of water or replace 1 liter to achieve this concentration. And in these tables, you can see what effect this has for the other electrolytes in the replacement fluid bags. And in theory, this customization of replacement fluid is the safest way to slowly increase your serum sodium concentration compared to conventional chronic renal replacement therapy or conventional hemodialysis. So, and the elegant and the nice thing is that kinetic modeling here meets reality, because what you can see is that after 24 hours, they readjusted the replacement fluid natrium concentration based on this kinetic model. And you can see that the predicted serum sodium concentration very much fits the measured levels. Let's turn to hyponatremia. Which population is at higher risk? It's the geriatric population and the critically ill. The mortality is sky high. It can be up to 100% if your serum sodium is above 160 for more than 10 days. The cause is excess or water loss or solute gain, and the therapy is just administration of hypotonic solutions. You can calculate your water deficit using the Androgue formula. But if additional dialysis treatment is necessary, it becomes a therapeutic challenge, because correction rate should not be higher than 0.5 milliequals per hour. So conventional hemodialysis is possible when your dialysate sodium is within 2 milliequals of serum sodium. But whenever your dialysate sodium is more than 3 to 5 milliequals below your serum sodium concentration, hypotension, cramps, and cerebral edema might be the consequence. So in severe, very severe hyponatremia, the correction rates with standard hemodialysis are high and not predictable. And the guidelines do not even mention hemodialysis. They suggest continuous renal replacement therapy as best option to treat severe hyponatremia. But again, you have to be careful, because commercially available replacement fluid natrium concentration is 140. You have to customize your replacement fluid solution, and there are case reports for that as well. Let's look at another emergency room situation. 43-year-old man with decreased consciousness for 3 days. He has a bipolar disorder, is taking lithium. His urine production is more than 1 liter despite profound dehydration. His natrium is 184, creatinine is high, white blood cell count is high. CT scan was unremarkable, but the diagnosis is AKID, and he is transferred to the ICU due to dehydration, incipient sepsis, and probably lithium-mediated diabetes insipidus. So total water deficit was calculated to be 10 liters, and 5 dextrose in water was started, planned delta sodium of 10, but 24 hours, sodium decreased to 177, but creatinine was still high, and the clinical situation did not improve, probably due to uremia, so CRRT was indicated. And this group used stepwisely modified hypertonic replacement fluid solution approach based on the sodium kinetic model I presented earlier for the treatment of, something went wrong. Again, just fill in the numbers, and this leads to calculation of 163 of replacement fluid sodium concentration you should aim at to start for the first 24 hours. And again, there are nice tables where you can have a look either to use 3% of sodium chloride or 23%, how many milliliters you have to add to the bag to adjust the sodium concentration of the replacement fluid solution. And again, kinetic modeling meets reality. So by using this stepwisely approach, the consciousness improved quite rapidly, and the patient could be discharged 2 weeks later with quite good serum creatinine levels. Let's look at hypercalcemic crisis. So how is it defined? Calcium above 7 milliequals per liter, and this is considered a life-threatening event. Why? Because the result can be confusion, coma, ECG abnormalities, cardiac arrest, acute kidney injury, nephrogenic diabetes insipidus, nausea, constipation, abdominal pain, volume depletion, and so on. And in more than 90% of cases, it's either malignancy-related or PTH-mediated. The other causes like vitamin D or vitamin A intoxication, thyrotoxicosis, adrenal insufficiency, thiazide use, immobilization, Milk-Kakali syndrome. The initial therapy always aims at lowering calcium below 6 milliequals within hours to eliminate the symptoms. Conventional symptomatic therapy consists of hydration, use of furosemide, glucocorticoids, bisphosphonates, denosumab, calcitonin. But there are only a small series of published cases, and there's no consensus on hemodialysis timing and prescription. The first question is, should we do it as first line, or rather as a rescue therapy if severe symptoms persist despite conventional therapy, or if AKI precludes adequate hydration? And the second question is, should we use serum dialysate calcium bath or 2.5 dialysate calcium concentration? So hemodialysis is clearly the best way to remove calcium. Calcium clearance is highest with hemodialysis. PD and forced diuresis are not that efficient. The driving force, of course, is the calcium gradient between the dialysate and blood. Interestingly, many centers use serum dialysate calcium baths. We don't do it, but those centers who do it can reduce serum calcium concentration without having hypocalcemic symptoms. Probably this is some kind of publication bias, but other groups presented evidence that it's equally effective to use 2.5 milliequals per liter dialysate calcium concentration. Of course, large calcium shifts may lead to cardiovascular instability. This is more common with serum dialysate calcium baths, so if you use it, you should adequately administer fluid before a hemodialysis session. Another emergency room situation, a 60-year-old gentleman who is weak and refuses to eat and drink. He has no disease record or any medication. His BMI is low, Glasgow Coma Scale is low, he has a decreased skin turgor, creatinine is 3, not dialysis dependent, but calcium is sky high. And he presents with ECG abnormalities. So the question is it malignancy related, is it primary hyperpower or other reasons? So the colleagues did a bone marrow biopsy, several kinds of tumor markers, they were all normal, but PTH was high and a hypotense lesion was found in the CT scan near the thyroidea. So after parathyroidectomy, a non-malignant parathyroid adenoma was found. But how was the case managed? Immediate hemodialysis was applied, 3 times 4 hours high flux hemodialysis session using 2.5 dialysate calcium concentration, and the calcium concentration was brought below 6. The patient developed polyuria due to this nephrogenic diabetes insipidus. All the conventional therapy I mentioned earlier was initiated and continued until parathyroidectomy. Post-parathyroidectomy, PTH was low, and the patient developed a hungry bone syndrome that could be managed with oral calcium and phosphorus and vitamin D. And 5 years after parathyroidectomy, PTH was 169 and creatinine was quite acceptable. So for the very last part of my presentation, I will discuss the management of metabolic acidosis and hemodialysis. What does KDIGO tell us? We should keep serum bicarbonate concentration above 22. But evidence from the DOPS analysis from Francesca Tentori showed us that dialysate bicarbonate concentration and the next session bicarbonate is not really associated, like I presented for potassium and for dialysate sodium. But here we have to be careful because we should avoid post-hemodialysis alkalosis and therefore restrict your dialysate bicarbonate prescription to 35. You should not increase it because it has been shown that rapid increase in blood pH and serum bicarbonate can lead to respiratory changes that lead to hypercapnia. It can lead to electrolyte imbalances, to arrhythmia and progression of vascular calcifications, and rather interestingly, to an immune system deficiency. It increases the risk of infection and altogether increases the risk of death. So whenever your serum bicarbonate is above 10, you can use your dialysate bicarbonate concentration of up to 35. But if your serum bicarbonate concentration is below 10, you should limit dialysate bicarbonate with 25 to avoid this tissue hypercapnia and the concomitant lactate production that has negative consequences for your patients. And in the very last slides, I will show you an interesting idea Turkish group had, because they asked the question whether the addition of hemodialysis during prolonged CPR might increase the risk or the return of spontaneous circulation in patients with intoxication-mediated severe metabolic acidosis. It might make sense because severe metabolic acidosis is common in CPR situation. It promotes arrhythmia and reduces cardiac output and the catecholamine effect. And I was quite surprised to find that there are 11 case reports on a similar topic where hemodialysis was added during refractory CPR situations for hyperkalemia. Okay, and this Turkish group now looked at intoxication-mediated severe metabolic acidosis that was refractory to conventional therapy. In the first patient, it was ethylene glycol intoxication, and you can see before hemodialysis, bicarbonate was 5 and pH below 7. And 30 minutes after CPR initiation, they added high-flux hemodialysis. And 45 minutes later, ROSC was observed, and patient was transferred to ICU, and hemodialysis continued for 4 hours. And in another patient, with metformin intoxication, and that was refractory to sodium chloride and bicarbonate, they added hemodialysis after 28 minutes, and they found return of spontaneous circulation after 50 minutes. So in both cases, it was high flux hemodialysis session with blood flow of 250, high dialysate flow, and only 2 patients, no control, of course. But the most interesting question to me was, is sufficient blood flow possible during CPR? Obviously, yes. Recirculation must be a big issue and multiple machine alarms. But at least it is an interesting way, and we should probably further investigate adding hemodialysis during CPR in patients with intoxication-mediated severe metabolic acidosis. So that brings me to my summary and some key takeaway. So in severe hyperkalemia, you can use the rule of 6. With hyponatremia, either you can do hemodialysis with reduced blood flow or chronic renal replacement therapy with customized replacement fluid sodium concentration using a sodium kinetic model. The same is true for severe hyponatremia. In hypercalcemic crisis, immediate hemodialysis with low dialysate calcium bars should be done, and in severe metabolic acidosis, probably rescue hemodialysis during refractory CPR might be something we should further investigate in the future. And with that, I thank you for your attention, and I'm happy to discuss the topics later on. Thank you.